Hey, social media fam, it's Amanda Curtis, nurse practitioner, and I'm just going to re-record the last episode because due to technical difficulties, it didn't come through. So we'll just go over what I was talking about before, which is the menstrual cycle. So little education, and again, I'm back in the clinic. So this is a picture of our hormonal monthly cycles as women. So you can see up here at the top is the ovarian cycle with the release of the egg, and here in the middle we have the anterior pituitary, that's LH and FSH, and then also the ovarian cycle of hormones, so estrogen and progesterone, and then the uterine cycle. You can see the shedding at the bottom, and that's our monthly cycle. Okay, so as women, I just like to educate, kind of go back to like biology 101, but I'll also post a picture of the cycle as well. You can Google this online, you can look at it, but what my goal as a practitioner is for women, especially in perimenopause, it is important because our bodies are still cycling, although they are in a little bit of a chaotic cycle, but they are still cycling. So we are supplementing what the body is naturally producing, and we should follow our menstrual cycles. And this is also my goal in menopause for women, is to continue giving that same rhythmic dosing of hormones. All right, so the estrogen and progesterone they have to have their time in the spotlight to do what they need to do best. So estrogen is our building hormone. It's going to grow our bones, the lining of our uterus, provide more blood flow for baby. These are things that respond in our body to signals, which are hormones. And then progesterone comes on board, and it causes the uterus to flourish and for it to become a place where the egg can implant. So this is just how our bodies naturally evolved and how they respond to hormones. So my goal as a practitioner is to continue talking to the body in that same rhythmic fashion. And so with that, I always like to caveat too, is that women in perimenopause, they still have an egg reserve. So although it's a low quality egg reserve, we still do have eggs that we are ovulating. So birth control can become important if you're not looking to have a child later in life. But this is something we need to have, a conversation we need to have if you are sexually active and not looking to have a baby. So then contraceptives become important. I'm happy to talk with my patients about options. One that I think is a very good option is going to be a Mirena IUD. It's a progestin coated IUD that sits in the uterus and thins the lining of the uterus. So some patients won't have menses because of that progestin lined IUD. There's also a hormone-free or progestin-free. It's called the Paragard, and that's a copper IUD. So these will prevent pregnancy, but they're not. The progestin may augment a little bit of hormone, but the Paragard will not. So those are the two options that I think are very helpful. Also, they stay local to the uterus instead of having more systemic effects like oral contraceptives would have. So along with this, thinking about this cyclic fashion, this is one of the reasons that I personally don't offer pellets at my clinic, is because this is the cycle that our body normally follows and naturally follows. So how am I supposed to create this cycle with a 3-month pellet that's inserted, and then you kind of go up on this, the medication goes into your system, and then as it peaks, and then it's going to come out of your system. So, but we don't have any control over how that is released, even though some will say that it's like a controlled release, a sustained release. You're going to have a peak and a trough. It comes up and it comes down. And so I cannot create that rhythmic cycle with a pellet. It's just not possible. And I know that some practitioners are going to say, well, that's just testosterone that I'm inserting. It's a testosterone pellet, but I can supplement a woman's testosterone at a lower level with a cream, right? Or even an injection. It's not something that we need to insert to the body. So I just think it's an unnecessary, and it doesn't mimic the woman's natural cycle, which is what I do. So again, in perimenopause, my goal for women is to supplement the naturally occurring cycles that are still occurring. And it's important that we understand that we track our cycles. I would use, there are lots of apps out there that you can use to do that. And you're just going to be augmenting or supplementing those cycles as they occur. And then as we get closer and closer to that final period and final menses, then your dose is going to adjust. So I always tell my patients, like, the amount that I give you will increase because your body is naturally decreasing as we get closer to that final period. So the dose changes. It's very important to track your symptoms, track your cycle, see what's going on with you, and then I'm here to advise my patients and to listen to them and to respond and to adjust doses accordingly. And then, oh, by the way, track labs. We correlate that with labs. So it's a very individualized process, and it's important that you have a practitioner who understands, number one, what they're looking for, how to correlate your symptoms that you're having with what's occurring, and then also lab values. So it's a very complicated process, but I'm trying to explain a little bit of the treatment plan so that my patients and also that everyone else is a little more educated on what women's bodies are doing and what our goal for treatment is. There's also a little bit of a debate between just symptom management. Are you going for symptom management? So that means relieving night sweats and hot flashes, the dryness that is occurring, or are we trying to reach optimal levels? So that's another conversation that I have with patients. Those are two different goals, because even a small amount of estrogen will improve symptoms, but that may not be the optimal dose. So all conversations to have with your practitioner, and let me know what other questions you guys have. I think we've covered perimenopause pretty well, but I'm going to move on in the next series. Will kind of be more focusing on menopause, and then we can focus on other hormones even. Okay, so have a great day. Bye.